Hi everyone, it's Hunter Hicks. Today we're going to look at diuretic, ACEs, and ARBs. Let's first look at the nephron because this is where a lot of our medications are working, obviously. In the proximal tubule, we have a ton of reabsorption of our sodium and our chloride. That's why diuretics that work at this area, like mannitol, one we're not covering today, causes a profound amount of diuresis, which might be helpful for acute glaucoma or even TBIs. When we look at our loop of Henle, we know that we have a thick ascending and a thin descending. The thick ascending is impermeable to water. Therefore, it pumps out sodium into the interstitium. When it pumps out all that sodium into the interstitium, this makes that interstitium hypertonic, thus wanting to pull fluid into that area. So the thin descending loop will push water out into that area. We then have the vasa recta here, which will reabsorb all that water back into the blood. We get about 20% of our reabsorption of our sodium chloride here. So our medications that work on the loop of Henle, we call loop diuretics, like Lasix. We get a good amount of diuresis from those as well. Lastly, when we look at the distal tubule, we know that there is still a degree of reabsorption here, really about 10%. This is where we're going to see some of our other diuretics happen here. Aldosterone happens here as well. Now we know aldosterone is going to reabsorb sodium. When we reabsorb sodium into the blood, we get passive reabsorption of water, therefore increasing our blood pressure. We also know that aldosterone is going to kick out both potassium and hydrogen. So when we talk about potassium-sparing diuretics that work on aldosterone, like spironolactone, we know that these medications can cause some degree of diuresis, though small, but it also can cause a risk for hyperkalemia, just like our ACEs and our ARBs. Let's go through all these medications now. When we look at diuretics, we really have three classes. Three big classes, I guess. So loop diuretics are going to work in that loop of Henle. So we know we get a good amount of diuresis. One of a good example here is Lasix. That's why the uses for Lasix sometimes is reserved for patients that have edema that we're trying to get off the body. Like we can see pulmonary edema or dependent edema that we see with heart failure. It's not so common to use in hypertension, whereas our thiazide diuretics are. However, we may see that. But again, it's really reserved for those patients when we're trying to get fluid off the body. Now, when we look at adverse reactions, anytime we increase diuresis, we're going to lose more electrolytes, specifically things like sodium and potassium. So we're at risk for hyponatremia and hypokalemia. We can also cause hypotension because we're just naturally losing more fluids off the body. Last but not least, Lasix, which is unique to loop diuretics, on ototoxicity, so we want to be watching that with our patients. Thiazide diuretics are now going to work more in the distal tubule. So we only get really about 10% of reabsorption in that area. Not to say thiazide diuretics don't cause diuresis, it's just to a lesser extent as our loop diuretics. Because if you look at the nephron, as you go down from the primary down to your loop, down to your distal tubule and the collecting ducts, more absorption happens early on and less absorption as you go throughout the nephron. So bigger absorption, more diuresis. Hence why mannitol is going to work in the primary, Lasix here, thiazide, and then potassium sparing. So as we go down, less diuresis overall. So thiazide diuretics, like hydrochlorothiazide, will cause diuresis just as much as our loops. That's why it's actually nice to use it for hypertension and even heart failure. Again, a lot of times you're going to see these diuretics combined with other medications for heart failure and CHF, like calcium channel blockers or ARBs or ACEs and stuff like that. Now, adverse reactions pretty much the same as loop because we're diuresing more. So hyponatremia, hypokalemia, maybe still a little risk for hypovolemia or low blood pressure, but they don't have the ototoxicity. Last but not least are our potassium-sparing diuretics. Now we have aldosterone blockers and non-aldosterone blockers. Today we're just going to talk about aldosterone blockers like spironolactone. Spironolactone itself, or our potassium-sparing diuretics, have very minimal diuretic effect. For that reason, you're not going to usually see them used by themselves just simply for the diuretic effect. They're usually combined with diuretics to help combat the hypokalemia we see, or they're just combined with other medications in general. Now, spironolactone, because it does block aldosterone, gives us a couple other things. One, we actually don't see the hypokalemia anymore. We see a degree of hyperkalemia. Remember, aldosterone kicks out potassium and hydrogen and kicks in sodium and water back into the blood. So if we reverse that, now we're retaining more hydrogen, and really what we worry about too is potassium. So it puts them at risk for hyperkalemia. That's why when we talk about ACEs and ARBs, if you combine this medication with them, you might increase your risk for hyperkalemia. But the good thing is when we block aldosterone, it might actually change some of those pathologic effects that we see with hypertension or heart failure. And we'll talk about that more later. But for that reason, this medication specifically, blocking aldosterone, can help decrease mortality in some of these disease processes. Another adverse reaction that's pretty unique to spironolactone is some of the endocrine effects. So we might see a degree of irregular menses in our women. We might see breast development or breast growth in our men. When we look at the RAS system, we know our renin is going to be near our juxtaglomerular cells. Renin is going to be released as it senses fluid coming or blood coming to the kidneys, or afferent or efferent. When it senses decreased perfusion, whether that be low hypovolemia, so decreased fluids, low blood pressure from just decreased cardiac output, or low sodium content, as we know we can get hyponatremia with hypovolemia, one of the causes of it, it's going to release renin. Renin will then tell angiotensinogen to go into angiotensin 1. Angiotensin 1 is inactivated, and it needs to be activated into angiotensin 2. The enzyme that is going to convert angiotensin 1 to angiotensin 2 is ACE, or the angiotensin converting enzyme. That's why when we talk about ACE inhibitors, it blocks this effect. Now, ACE is found throughout the body, but mostly a high amount of it is found in the lungs. The other thing ACE does is it's going to take bradykinin and convert it into inactivated products. We know that bradykinin can cause a lot of our inflammatory effects that we're going to talk about, which is why it relates to side effects with these medications. So again, ACE is going to give us angiotensin 1 to angiotensin 2, but also bradykinin into its inactivated form. That's why sometimes ACE will be referred to as kinase 2. Now, angiotensin 2 does a few things. One, it's just a potent vasoconstrictor. That's why you'll see in some of the critical care areas, like the ICU, sometimes they use angiotensin 2 as a pressor because it will increase blood pressure. Angiotensin 2 has also been linked to a lot of our pathological or anatomical changes with both the heart and the vessels. That's why by blocking it, we actually might block some of those changes and decrease mortality with our patients. Outside of that, it actually gives us aldosterone. Aldosterone, which we've talked about a lot here, is going to increase both sodium and water content in the body, which will give us increased blood pressure, and then it's going to spit out potassium. Just like angiotensin 2, aldosterone also has been linked to causing some of those pathological changes we see in both the heart and the vessels. Now let's look at some medications that can block that process there. So we have our ACE inhibitors, which are angiotensin converting enzyme inhibitors. So ACE inhibitors are things like lisinopril, captopril, and then enalapril. Now, uses for these medications is a big one is hypertension. A lot of patients with hypertension are on ACE. The reason for that is they just work well by blocking the RAS system, right? If we block angiotensin 2, therefore we don't get the vasoconstriction. If we are also blocking aldosterone, we don't get that increased water and sodium content. Now, it's also been linked to actually decreasing mortality in patients with hypertension. That's why it's usually our first go-to outside of our ARBs. The other thing can be used in heart failure, and the reason for that is all the reasons for decreasing blood pressure, which will decrease afterload on the heart, decreases venous pressure or that venous return, but it also has been linked to a little bit of a diuretic effect. That's because it will actually increase perfusion to the kidneys, which might give us a little bit of that diuretic effect with our ACE inhibitors. Outside of that, ACE inhibitors can be used for diabetic nephropathy. Now, some of the adverse reactions is the first dose hypotension. What that means is patients, especially patients with very high blood pressure, if they take an ACE inhibitor, they'll kind of reset that baroreceptor very fast. Therefore, they'll drop their blood pressure, and your body's not used to that. So they may feel dizzy and lightheaded, and they can pass out. That's why you want to make sure they know about it. And that's why sometimes when these patients first take this, they might take it at night or while they're going to bed. Therefore, we reduce the risk of them passing out. Outside of that, hyperkalemia is always a risk here because we're blocking aldosterone, therefore we're retaining more potassium. This can also cause two things that are pretty specific with ACEs. One is the cough. And the idea behind that is if we block ACE or kinase 2, we get more bradykinin in the body because it never becomes inactivated. Therefore, more inflammation in general with the body might cause this nagging cough. Now, the cough is only seen around 10% of patients. but it's more likely in patients maybe with Asian descent, patients that are women, and patients that are older, above the age of 65. It's one of the main reasons patients switch from an ACE to an ARB. Outside of that, if they stop the medication, really about 1 week to 10 days, that cough should go away. Now, angioedema, which is a very large swelling or edema in the face, can be very life-threatening. Angioedema can be linked to ACEs. Now, only 1% of patients will get this angioedema. And again, we think it's from all that bradykinin released. I want to make it very clear that if your patient's on an ACE and they don't get that angioedema right away, it does not mean that they are safe from developing it later while on the medication. The angioedema can happen at any point during this patient taking an ACE. Now, angiotensin II receptor blockers, or ARBs, like losartan and valsartan, are usually secondary to ACEs. The reason for that is they can be used for things like hypertension and heart failure and diabetic nephropathy, just like ACEs are. But they aren't really linked to decreasing mortality as much as ACEs are. That's why we usually start someone on an ACE, especially for hypertension, and then if they can't do it because of the cough, we go to an ARB. Now, the adverse reactions to ARBs are pretty similar to ACEs. However, we don't see that nagging cough, again, the major reason people want to go to an ARB, but we can see angioedema. And the reason for that is maybe there's still some bradykinin effect with these ARBs. The other thing I want to make very clear is that patients that are on ACEs that had an angioedema effect have an 8% cross reaction. So if they've had angioedema with an ACE, there's an 8% chance they might actually have it with an ARB as well. So just make sure you're watching them. In general, both these medications and renin antagonists, which we're not talking about today, should not be used in pregnancy as they've been shown to cause issues with the baby. So if your patient has chronic hypertension before 20 weeks or gestational hypertension without signs of pre-E after 20 weeks, we want to get them off this medication as soon as possible and a safer antihypertensive med. They also should not be given with NSAIDs. NSAIDs, which we know are both cyclooxygenase 1 and 2 inhibitors when we look at our first generations, block prostaglandin in the kidney. Therefore, they might actually make these medications not work as well. So if they're on a daily aspirin, which a lot of these people might be if they're post-MI or they've had a stroke or something like that, that might decrease the overall effectiveness of these medications. Again, ACEs and ARBs for hypertension and for heart failure are commonly prescribed with a diuretic. That's all I have for you guys today. If you have any questions, please leave me a comment. If you like this video, give me a like if you would, and I'll see you next time. Thank you.